A patient rolls into your ED with a blood pressure of 70/40. They're confused, tachycardic, and their skin is clammy. You got maybe minutes before this gets a lot worse. So where do you even start? Welcome to the Differential Diagnosis series from M3 Medical Education. Today we're tackling hypotension, not just a list of causes, but a systematic framework for thinking through it in real time, the way a great clinician does. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Before we build our differential, we need to internalize one equation. MAP equals cardiac output times systemic vascular resistance. That's it. That single equation is your entire framework. If the blood pressure is low, it's because cardiac output dropped, SVR dropped, or both. And because cardiac output itself equals heart rate times stroke volume, which is determined by preload, contractility, and afterload, you can trace every single cause of hypotension back to one of these variables. Shock, by the way, isn't just low blood pressure. Shock means inadequate tissue perfusion plus cellular hypoxia, and critically, hypotension isn't always required. Patients can have normal-looking blood pressures and still be in shock if their baseline runs high. That clinical context matters. So let's meet the four types of shock. Distributive shock is the only type with low SVR. The vessels are wide open and the cardiac output is paradoxically high. Cardiogenic shock is pump failure, low CO, high SVR, and backed up filling pressures. Hypovolemic shock is an empty tank, low CO, high SVR, and low filling pressures. An obstructive shock looks just like cardiogenic on the numbers, but the primary problem isn't the myocardium. Something is blocking blood flow into or out of the heart. In tamponade and tension pneumothorax, the ventricles are structurally normal but can't fill. In massive PE, the blockage is in the pulmonary vasculature, and you'll see acute right ventricular dilation and failure from the sudden afterload. Here is the board pearl you need locked in. Low SVR equals distributive, period. Every other type of shock has high SVR. If a board question tells you the SVR is low, you don't need to read another word. The answer is distributive. Let's go deeper on distributive shock, because this is your most common type and it has the most variety. The heavyweights are sepsis, anaphylaxis, neurogenic, and adrenal crisis. Septic shock is defined by a dysregulated host response to infection with persistent hypotension despite adequate fluid resuscitation and an elevated lactate. Anaphylaxis hits fast, allergen exposure, urticaria, bronchospasm, angioedema, hypotension. The neurogenic patient is the one that will fool you. They've had a spinal cord injury, and because they've lost all sympathetic tone, they're vasodilated A&D bradycardic. Almost every other shock presentation is tachycardic. Neurogenic is the classic exception, though cardiogenic shock from bradyarrhythmias or beta blocker toxicity can also present with a slow rate. And then there's adrenal crisis, the great mimic. Think chronic fatigue, weight loss, a precipitating stress, and labs showing hyponatremia and hyperkalemia. Primary adrenal insufficiency gives you hyperpigmentation from all that excess ACTH. These patients don't respond to vasopressors until you give them steroids. The classic presentation of distributive shock, especially early sepsis and anaphylaxis, is warm, flushed skin, bounding pulses, and wide pulse pressure. Neurogenic shock is warm but dry and lacks the bounding pulses because of bradycardia and venous pooling. Now for the cold shock types. Cardiogenic and hypovolemic share the same hemodynamic fingerprint, low CO, high SVR, cold, clammy skin, tachycardia. But here's how you tell them apart. Feel the neck veins and listen to the lungs. Cardiogenic shock means the pump has failed. Fluid backs up. You get elevated JVP, bilateral RALS, an S3 gallop, and peripheral edema. The most common cause is a large anterior STEMI, but myocarditis, severe arrhythmia, and acute valvular disease can all do it. Hypovolemic shock, on the other hand, means the tank is empty. Flat JVP, dry mucous membranes, tachycardia, and you're looking for a source of volume loss, trauma, GI bleed, ruptured ectopic, ruptured A for the hemorrhagic side, vomiting, DKA, burns, and third spacing on the non-hemorrhagic side. Lose 30 to 40% of your blood volume, that's class 3 hemorrhage, roughly 1.5 to 2 liters, and you're in frank shock with confusion, tachycardia, and hypotension. Beyond 40% is class 4, pre-terminal. Now there's one more type that's easy to miss, and that's obstructive shock. It's the rarest, under 1% in the ED, but it's arguably the most treatable if you catch it early. The hemodynamics look just like cardiogenic, low CO, high SVR, high CVP. But the primary problem isn't the heart muscle, it's an obstruction to flow. Cardiac tamponade gives you Beck's triad, hypotension, JVD, and muffled heart sounds, plus pulsus paradoxus greater than 10 millimeters of mercury. Tension pneumothorax gives you hypotension, JVD, and absent breath sounds on one side with tracheal deviation away. That one is a clinical diagnosis. Do not wait for a chest X-ray. And massive PE causes acute right ventricular failure with hypoxia and tachycardia. One more pearl. Kussmaul's sign, JVP rising with inspiration, points to constrictive pericarditis, not tamponade. That distinction comes up on boards. If this is helping you build your approach to the hypotensive patient, hit like and subscribe. It helps us reach more medical students who need this content. Now let's talk about how you actually put this to work at the bedside before a single test result comes back. The history can get you most of the way there. Fever and an infection source point to sepsis. An allergen exposure followed by urticaria and wheezing is anaphylaxis until proven otherwise. Chest pain has a wide differential MAP dissection, tension PTX. Trauma or GI bleeding goes straight to hypovolemic. A spinal cord injury, especially with bradycardia, is neurogenic. And the patient who comes in with chronic fatigue, weight loss, and got sick last week, think adrenal crisis. On exam, the single most useful tool is skin temperature. Warm and flushed equals distributive. Cold and clammy equals cardiogenic or hypovolemic. Then check the JVP. High filling suggests cardiogenic or obstructive. Low, flat JVP suggests hypovolemia. Add in what you hear in the lungs and see in the heart, and you've narrowed your differential dramatically without ordering anything. You've narrowed it with history and exam. Now let's confirm with testing. For any undifferentiated shock, you fire off a standard panel first: lactate, CBC, BMP, LFTs, troponin, COGS, ABG, urine, pregnancy test, ECG, and chest X-ray. Lactate is your most important single number. Greater than 2 means tissue hypoperfusion. Greater than 4 means severe. Serial lactates guide your response to resuscitation. But the real game changer in the last decade is point-of-care ultrasound. The rush exam, pump, tank, pipes can tell you in under 5 minutes what type of shock you're dealing with. The pump views assess LV and RV function and look for pericardial effusion. The tank views check the IVC, collapsible means hypovolemia, distended means volume overload, plus lung B lines for pulmonary edema and free fluid in the abdomen. The pipes views look at the aorta for AA or dissection and check the legs for DVT to raise PE suspicion. Then you layer on targeted testing, CTPA for PE, echo for cardiogenic, cortisol and cosintropin for adrenal crisis, tryptase for anaphylaxis. Here's your algorithm when you're standing in front of a hypotensive patient. First question, is there end organ dysfunction? Altered mental status, oliguria, lactate over 2. If yes, this is shock, not just low blood pressure. If no, you're looking at orthostatic hypotension medication effect or baseline low blood pressure. Second question, warm or cold? Warm means distributive, start looking for a source. Cold means go to question 3. Third question, what are the filling pressures? Focus the IVC. Collapsible with low JVP means hypovolemia. Find the source of loss. Distended IVC with high JVP means you're on to question 4. Fourth question, what does the echo show? Poor LV function points to cardiogenic shock. But if you see isolated RV dilation with a normal LV, that's a massive PE until proven otherwise, and that's obstructive, not cardiogenic. Don't get tripped up. Poor RV does not automatically equal cardiogenic. Normal-looking ventricles that can't fill? Think tamponade or tension pneumothorax. 3 questions get you to the answer most of the time. The fourth confirms it. You've classified the shock. Now what do you actually do? And here's the beauty of a mechanism-based approach. The treatment follows logically from the diagnosis. Low SVR? Give a vasoconstrictor. Norepinephrine is your first-line vasopressor for septic shock. That's the Surviving Sepsis campaign guideline. Add vasopressin second, epinephrine third. Fluid resuscitate with 30 milliliters per kilogram of balanced crystalloid, push antibiotics early, and get source control. For anaphylaxis, it's IM epinephrine, 0.3 to 0.5 milligrams into the thigh right now before antihistamines, before anything else. Pump failure? Support the pump with inotropes like dobutamine or milrinone and get that STEMI patient to the cath lab. Empty tank? Fill it blood products in 1:1 ratio for massive hemorrhage, crystalloids for non-hemorrhagic losses, and control the bleeding source. Blocked outflow? Remove the obstruction. Needle decompress the tension PTX before you intubate. Tap the pericardial effusion. Lyse the massive PE. And for adrenal crisis, give hydrocortisone 100 milligrams IV right now. The unifying principle across all of this: treat while you diagnose. Don't wait for a complete workup before you start resuscitating. Let's bring it all together. 4 types of shock: distributive, cardiogenic, hypovolemic, and obstructive. One unifying equation: MAP equals CO times SVR. The approach is always the same: figure out which variable is broken, and the treatment follows. Low SVR means distributive. Say that in your sleep. Warm skin versus cold skin is your fastest bedside discriminator. JVP tells you full versus empty. And within the cold, full patients, the echo tells you cardiogenic versus obstructive. The can't miss diagnoses are tension PTX, cardiac tamponade, massive PE, septic shock, anaphylaxis, adrenal crisis, and the surgical emergencies, ruptured AA, ruptured ectopic. These reward the clinician who thinks in frameworks, not lists. If this video helped you feel more confident the next time a hypotensive patient rolls in front of you, smash the like button and subscribe for more from the M3 Medical Education series. We've got more differential diagnosis videos coming, plus acute care, drug classes, and a lot more. See you in the next one.